Joint genetic inhibition of PCSK9 and CETP and the association with coronary artery disease, a factorial Mendelian randomization study. A study by Arjen Cupido and colleagues from the University of Utrecht, University of Amsterdam, University College London, and University of California, Los Angeles. Clinical guidelines suggest that patients at high risk for cardiovascular disease should be treated with lipid-lowering therapies, with an LDL-C target of less than 70 mg per deciliter. Only 30% of all patients meet this target, and combination therapy is then suggested. Even with the options ezetimibe and PCSK9 inhibitors, this number increases to about 60%. This means that there is still an unmet need for additional lipid-lowering agents. CETP inhibitors are a class of LDL cholesterol-lowering drugs with a troubled history. 4 CETP inhibitors have been investigated in clinical trials. However, most clinical trials were terminated due to futility, or revealed only a modest reduction in cardiovascular disease risk. This is in discordance with genetic studies, which showed that genetic variants in CETP are associated with a similar risk compared to variants in the HMGCR gene, which encodes the target of statins. These contradictory results are attributed to compound-specific effect profiles, including side effects. One genetic study, however, suggested that the failures of some of these compounds was because a large proportion of patients in the clinical trials were also using statins. The combination of statins with CETP inhibitors would result in a discordant reduction in cardiovascular disease risk, compared to the effect on LDL cholesterol. 2 novel Phase 2 and 3 trials are investigating CETP inhibitors in high-risk patients on maximally tolerated lipid-lowering therapies, including PCSK9 inhibitors. It is unknown if the combined inhibition of CETP and PCSK9 will result in meaningful or attenuated effects on cardiovascular disease. The authors therefore designed a so-called Mendelian randomization study and aimed to assess the validity of CETP as a therapeutic target when combined with a PCSK9 inhibitor. In Mendelian randomization, genetic variants are used as instrumental variable to assess the causality between an exposure and an outcome. For example, genetic variants associated with LDL-C can be used to assess the causal connection between LDL-C and cardiovascular disease, without the risk for confounding or reverse causation that typically limits observational studies. A comprehensive review of interpreting Mendelian randomization was published by Davies, Holmes and Smith in the British Medical Journal in 2018. Mendelian randomization evidence is typically placed between observational evidence and clinical trial evidence. Mendelian randomization studies can be performed using summary data from genome-wide association studies, or using individual participant data from large biobanks. Here, the authors used both approaches. This study consists of a few steps. In Step 1, the authors constructed genetic scores for CETP and PCSK9 using genome-wide association studies on CETP and PCSK9 levels and validated the associations with cardiovascular disease. In Step 2, the authors used the genetic variants to construct genetic scores in individual participant data from the UK Biobank, and looked at the effects of genetically proxied lower CETP and PCSK9 levels on lipids and disease. In Step 3, the authors performed a so-called 2x2 factorial Mendelian randomization study, of which the design is shown here. They combined the 2 genetic scores to generate for groups in the UK Biobank, a group with genetically proxied higher CETP and PCSK9 levels, a group with genetically proxied lower CETP and higher PCSK9 levels, a group with genetically proxied lower PCSK9 and higher CETP levels, and a group with genetically proxied lower CETP and PCSK9 levels. The authors then looked at the differences in lipids and disease between these groups. First, they validated that both genetic instruments are associated with coronary artery disease, using external genome-wide association data. They then constructed the genetic scores in the UK Biobank, and found that genetically proxied lower CETP levels were associated with decreased LDL-C, triglycerides, and ApoB levels, and with increased total cholesterol, HDL-C, and ApoA1. Genetically proxied lower PCSK9 was associated with reduced total cholesterol, LDL-C, and ApoB levels. When assessing clinical outcomes, the authors observed that genetically proxied lower CETP levels were associated with reduced odds for coronary artery disease and increased odds for age-related macular degeneration. Genetically proxied lower PCSK9 was associated with reduced coronary artery disease odds and with lower odds for heart failure, although this association did not meet the threshold for multiple testing. The authors then performed the 2x2 factorial Mendelian randomization study. The reference group is the group with genetically proxied higher CETP and PCSK9 levels. They observed additive associations on all lipids and lipoproteins for the genetically proxied combined lower CETP and PCSK9 group compared to either lower CETP or PCSK9 alone. Using interaction models, they did not find a statistically significant interaction that could indicate an attenuation of the combined association. The authors observed similar additive effects for all clinical outcomes. The genetically proxied lower CETP and PCSK9 group show additive effects compared to either lower CETP or PCSK9 alone. Again, using interaction models, they did not find a statistically significant interaction that could indicate an attenuated association. To summarize, this study found that genetically proxied lower CETP and PCSK9 levels are additively associated with lipids and the risk for coronary artery disease. These data suggest that pharmacological CETP inhibition combined with PCSK9 inhibition should result in additive effects. Finally, the association found with age-related macular degeneration shows how Mendelian randomization can highlight clinical outcomes of interest for further study in clinical trials. This research was published in JAMA Cardiology 2022.